morning, dear ladies and gentlemen. Let me also say good afternoon, good evening to those who join from different parts of the world. May I know whether I'm audible to everyone? And that you can see my...
Yes, Doctor, you're audible.
Okay, thank you. I would like to present the findings of our study titled Characteristics Associated with Successful Treatment Outcome in Children with Overweight and Obesity at a Tertiary Care Obesity Management Clinic in Sri Lanka. The overview of my presentation will include the background, objectives, methods, results, conclusion, and limitations. As you may be aware, childhood obesity is a global health crisis. The worldwide prevalence of childhood overweight and obesity has increased at an alarming rate over the past 3 decades. According to the reports of the World Health Organization, the global prevalence of childhood obesity in 2016 was 7.8% in boys and 5.6% in girls. The majority of obese and overweight children live in developing countries, where the rate of increase is 30% higher than developed nations. A recent Sri Lankan survey showed a prevalence of obesity at 10.3% and overweight at 11.3%. A study conducted in the same draining area of teaching hospital Peradeniya, where this study was conducted, found a prevalence of 7.81% of overweight and 6.79% of obesity among a group of school children. Without intervention, obese children are likely to stay obese in adulthood and develop non-communicable diseases at a younger age. Therefore, early detection and initiation of weight management is extremely important. Management of overweight and obesity involves lifestyle interventions that include dietary, physical activity, and behavioral modifications. Most studies published to date demonstrate either low or only short-term benefit from lifestyle modification programs. Multiple systematic reviews that analyzed effectiveness of various combinations of treatment programs with durations ranging between 2 to 24 months on different age groups have demonstrated less than satisfactory results. Across studies, lack of adherence to lifestyle modifications is shown to be a major drawback in the achievement of weight reduction and stabilizing body weight over longer periods of time. Therefore, factors affecting the response to lifestyle modifications is necessary to plan strategies to achieve better outcomes. Several factors as predictors of outcome have been reported through retrospective analysis of several weight reduction programs. Predictors of good outcome have been suggested as younger age, lower initial BMI, shorter duration of being obese, higher level of maternal education, and family involvement. While being an adolescent male, high-calorie breakfasts, initial higher BMI, low maternal education, and parental obesity have been suggested as predictors of poor outcome. All these evidences are from Western high-income countries, and data from low and middle-income countries, including Sri Lanka, are sparse. Hence, our study intends to fill this gap in evidence to some extent. Objectives. The general objective was identify characteristics associated with successful obesity management in children with overweight or obesity. Specific objectives were identify demographic, medical, and lifestyle characteristics associated with successful obesity management and to evaluate the efficacy of the factors associated with the positive outcome. Ethics approval was obtained from the local ethics review committee. The study sample included children aged 1 to 15 years who were registered at the Pediatric Multidisciplinary Obesity Management Clinic between 2017 and 2020 at Teaching Hospital Peradeniya, a tertiary care hospital in the central province of Sri Lanka. Data were collected at the initial visit and the follow-up visits using an interviewer-administered questionnaire. Subjects with overweight or obesity who have completed 6 months follow-up visits were considered for the analysis. Overweight was defined as BMI for age between +1 SD and +2 SD, and BMI for age more than +2 SD as obesity. Children with chronic medical conditions, physical disability, and cognitive impairment were excluded. Out of 417 potential subjects, with the first visit at 1 to 15 years, within the review period, 16 were excluded as per exclusion criteria. Another 307 children did not complete the 6 months duration due to various reasons. The final outcome analysis sample of 94 who have completed 6 months program were identified and considered for further analysis. This slide outlines the clinic-based obesity management program. The multidisciplinary team that provides the obesity management intervention consists of a clinical nutritionist, a consultant pediatrician, and middle-grade pediatric medical officers. The main goals of the obesity management program are reduction in body weight and promotion of healthy lifestyle practices through changes in behavior. During the initial visit, detailed information of each and every patient is obtained by medical officers. A comprehensive past medical history, medication history, and comorbidities are documented. They obtain a 24-hour and a periodic dietary recall of consuming complex and refined carbohydrates, animal origin foods, dairy products, fruits, vegetables, deep fried foods, sweets, beverages, and salty food. They also record duration of physical activity, general activity, duration of sleep, and the average hours per day of screen time. The psychological motivation of the child and parents regarding obesity management is documented. The anthropometric measurements are taken by trained medical officers according to WHO standards. Physical examination is carried out by the consultant pediatrician. Individualized lifestyle modification advices are given based on the initial assessment details of the child and family. Either weight reduction or weight maintenance could be the target, depending on the age and the initial BMI. A dietary plan is given by the consultant clinical nutritionist for every patient at the beginning of the program. The dietary plan consists of an individualized, balanced, low-calorie diet. Behavioral changes targeting increased physical activity, reducing sedentary behaviors, and stimulus control to minimize food craving are discussed and customized for each patient. All patients are followed up monthly for the first 3 months and 2 to 3 months monthly thereafter, depending on the progress in weight reduction. At each follow-up visit, children and families are individually seen by doctors, and the lifestyle intervention is continually reinforced. The nutrition and physical activity goals are refined and monitored, and barriers to implementation are addressed. Data analysis. Data was entered to SPSS version 25, described using proportions and means with 95% confidence intervals. To establish associations between variables, chi-square t-tests along with difference between means and correlations were used. Regression analysis was applied to explore associations between dependent variables and multiple independent variables. Anthropometric variables including the relative weight, height, body mass index for age, ZBMI, and waist circumference were described with the means with 95% confidence intervals. Adherence to lifestyle modifications were evaluated under the categories of diet, consumption of processed foods such as instant noodles and snacks, biscuits, etc., physical activities, sedentary behaviors including screen time and sleep duration. Behavioral variables were assessed, including food craving behavior and motivation. Chi-square t-tests, as appropriate, were used to compare the baseline demographic, clinical, and lifestyle characteristics of the groups. A logistic regression model was applied to identify statistically significant associations with treatment response. Response to lifestyle modification program was taken as the dependent variable, while the characteristics significant at p-values less than 0.05 in univariate analysis were taken as possible covariates in the model. Results. This slide outlines the demographic characteristics of the 94 subjects who completed 6 months follow-up. The ethnic diversity of our study population shows that 87.2% were Sinhalese, while 4.3% and 8.5% were Tamils and Muslims respectively. Gender distribution shows a slight predominance of males as shown here. The positive response was taken as reduction of BMI Z score. Negative response was taken as an increment of the BMI Z score during the follow-up period. According to the findings, 85.1%, which is as a number 80 subjects, have shown a positive response, while 14.9% had a negative response. This table shows a comparison between the positive response group and the negative response group in terms of adherence to 7 lifestyle factors that are focused in their obesity management program. Adherence to diet, screen time, duration of sleep, general physical activity and physical exercise, motivation, and food craving are the factors compared. As you can see, statistically significant difference in the level of motivation is seen between the two groups. Logistic regression model. The same factors based on the results of the chi-square test were identified and logistic regression was applied to create an explanatory model. Logistic regression returned a model with screen time and food craving as explanatory variables for changes in BMI. Compared to screen times over 4 hours, screen time of 1 to 2 hours and 2 to 4 hours were positively associated with loss of BMI. And no food craving was a protective factor. Screen time more than 1 hour was identified as a risk factor for negative response to treatment. Demographic and dietary factors were not significantly associated with reduction of the said BMI. Conclusions. These are the conclusions we arrived at in analyzing our results. Characteristics of successful treatment outcome we have identified are the reduced screen time and self-control of food craving behavior. Sex, ethnicity, paternal education, and the age of initiation of the obesity management program did not show a statistically significant impact on the completion of the follow-up. Previous studies have demonstrated mixed results on the association of age and sex with the follow-up of obesity programs. Most of the studies showed no association with the age. Based on these findings, both primary and tertiary care obesity management programs can focus on counseling regarding minimizing screen time and improving stimulus control to prevent food craving behavior. Reinforcement of positive behaviors in these children may enhance the likelihood of adopting a healthy lifestyle for the rest of their lives. Once identified, the modifiable factors could be addressed using novel approaches and reinforcement. These are the recommendations we could make based on our results. We identified few important limitations of our study. The documentation of lifestyle data were based on parental reporting, which could have been a source of bias. Some lifestyle factors, such as family involvement and depressive features in the child and parents, were not assessed in this study. Although our population included all ethnicities, the Tamil ethnic group is less well represented. Predominant vegetarian dietary habits among Tamil people may have contributed to reduced prevalence of obesity among them. However, the variations in dietary habits between different ethnicities were not assessed in our study. I would like to thank our patients and their parents for participating in their study, and also the members of the multidisciplinary obesity management team. Also, the Department of Pediatrics, Faculty of Medicine, University of Peradeniya, for their constant support in carrying out the research in obesity. And last but not least, I would like to thank the organizing committee of the World Congress on Primary Healthcare and Medicare Summit for giving me this opportunity to present the findings of our study.